Hello everybody, so thank you for watching my video today, and in today's video we're going to be looking at the high yield electrolyte disturbances with ECGs for medical school final exams. So just a little bit about the medicine guide. So the medicine guide aims to support medical students throughout their entire journey at medical school. So I've got videos such as how to be successful during the pre-clinical years at medical school, how to be successful during the clinical years at medical school, how to get the most out of GP placements, how to get the most out of hospital placements, how to succeed in your clinical OSCEs, and I've also got a video focusing on the high yield paediatric conditions that crop up in medical school final exams, such as high yield child with mass, high yield vomiting child, high yield congenital heart disease, high yield rashes, high yield limping child, and high yield genetic conditions for finals. Similarly, I've got a high yield obs and gynae edition focusing on videos such as chronic abdominal pain, gynecological cancers, acute abdominal pain, obstetric emergencies, and STIs for finals. So this video, in conjunction with my other similar videos, is part of my high yield cardiology edition for finals, including atrial fibrillation, pleuritic chest pain, infective endocarditis, aortic coarctation, and today's video, which is high yield electrolyte disturbances with ECGs for finals. So if you enjoy my video today, please give me a thumbs up, please subscribe to my YouTube channel, and please share this video with your friends. So today's video is going to be more of a quiz. So this quiz will involve the 5 high yield ECG electrolyte disturbances. So I'll have 5 questions with 5 different ECGs, and it will be up to you to diagnose what you think is a possible underlying electrolyte abnormality leading to this particular ECG. So I'll give you about 20 seconds for each ECG. So let's begin. So number 1, what is the electrolyte disturbance? So I'll give you 20 seconds for this ECG. You can either choose to pause the video at this point, or you can wait 20 seconds later. Okay, so the answer is hypokalemia. So let's have a look at this. So firstly, you've got T-wave inversion, and the T-wave inversion is most prominent, I thought, in leads 2 and leads 3. There's also a U-wave found in V5, V6, V4, leads 2, a little bit in V2, and definitely in V3. So the T-wave inversion and the prominent T-waves, I think, are quite classical of hypokalemia. It describes this push and pull phenomenon. So you've got the pushing down, so that T-wave inversion, and you've got the pulling up, which is the prominent T-wave. And another key feature of hypokalemia is ST depression, and ST depression, I think, in this ECG is most prominent in V4, V5, V6, and a little bit in V3, but definitely in V4. Okay, so let's have a look at some of the key features of hypokalemia that you need to remember for your finals. So hypokalemia is caused by using thiazide diuretics, loop diuretics, Conn syndrome, Cushing syndrome, and an overdose with insulin. So the ECG features of hypokalemia includes inverted T waves, a prominent T wave, ST depression, also a prolonged QT interval and a prolonged QU interval. Now I would say the key classic features of hypokalemia that you definitely need to remember for final exams and also for OSCEs are the inverted T waves, prominent T waves and ST depression. Now in terms of treatment, we can either orally replace the potassium if the hypokalemia is quite mild. However, if the hypokalemia is very severe, for instance if the potassium levels are less than 2.5, you definitely want to use IV replacement. So we offer patients IV potassium chloride at 20 millimoles per hour. Okay, so let's have a look at the next ECG. Again, you can either choose to pause the video here or wait 20 seconds, at which point you'll be given the answer. Okay, so let's have a look at the answer. So this is an example of hyperkalemia. So the first thing that I saw when I looked at this ECG was the tall tented T waves, and this is very classic for hyperkalemia. So if you can't remember anything else about hyperkalemia, then the one sign that you should definitely remember are the tall tented T waves. So the tall tented T waves you can see most clearly in leads V2, V3, V4, V5. You can also see it in V1 and V6, but I think it's most prominent in leads V2, V3, V4 and V5. Another feature that's very classic of hyperkalemia are absent P waves, and you can see that in V6 because you've got your QRS complex and then you've got a tall tented T wave, you don't have any P waves. And also a broad QRS complex, so that's when your QRS complex is more than 2 small squares, and that again is a key feature of hyperkalemia. So now let's have a look at hyperkalemia in a bit more detail. So hyperkalemia is caused by an acute kidney injury, an AKI. It's caused by Addison's disease, the use of spironolactone because it's a potassium sparing diuretic, ACE inhibitors such as ramipril, rhabdomyolysis and tumor lysis syndrome. So the key features of hyperkalemia on an ECG includes tall tented T waves, broad QRS complex, absent P waves, also a short QT interval and ST depression is found in hyperkalemia. Now we can treat hyperkalemia by initially stabilising the cardiac membrane, and that's really to protect the cardiac membrane. So we give patients IV calcium gluconate. Then we have to shift potassium from the intracellular fluid compartment out into the extracellular fluid compartment. So we can either give patients combined insulin and dextrose infusion, or we can give patients nebulized salbutamol. Then we need to remove potassium from the body. So we can either remove the potassium from the body by using an oral or enema calcium resonium, offering patients loop diuretics or dialysis. Now, calcium resonium in an enema form is more effective than the oral calcium resonium. Now, in terms of dialysis, hemofiltration or hemodialysis should be considered in AKI patients who have persistent hyperkalemia. Okay, so our third ECG. So again, I'll give you 20 seconds, or you can choose to pause the video. Now this one's a little bit more difficult, I think. Okay, so let's look at the answer. So this is an example of hypercalcemia. Now this one's quite tricky, I thought. So with hypercalcemia, one of the signs of hypercalcemia are Osborne waves. So Osborne waves is this little hump that you can see, this little bump after the QRS complex. Now Osborne waves I wouldn't say are specific because the Osborne waves are also found in other conditions and other scenarios. So Osborne waves can also be found in hypothermia, but something that you need to be aware of is that in terms of electrolyte disturbances, Osborne waves are found in hypercalcemia. Okay, so let's look at the key points that you need to keep in mind when you're thinking about hypercalcemia. So the causes of hypercalcemia are primarily due to primary hyperparathyroidism. So on a bone profile screen, primary hyperparathyroidism will present with high parathyroid hormone, high calcium, high vitamin D, but low phosphate. Another key cause of hypercalcemia involves malignancy and sarcoidosis. So examples of malignancy which can lead to hypercalcemia involves bone metastases, myeloma, and squamous cell lung cancer, where parathyroid hormone related protein is secreted. Features of hypercalcemia on an ECG involves a short QT interval and an Osborne wave. Like I said previously, an Osborne wave is found in other pathologies too, so just be cautious of that. And short QT interval is a very classic sign of hypercalcemia. And in terms of signs, so this is something that you should know very well. There's a mnemonic known as bones, stones, groans, and moans. So let's go through this one by one. So bones is referring to bone aches and bone pains. Stones refers to kidney stones. Groans refers to confusion, dementia, depression, and memory loss. And finally, the moans refers to constipation, abdominal pain, nausea, and vomiting. Other signs of hypercalcemia includes corneal calcification and hypertension, but the most common exam style question around hypercalcemia will typically involve a patient presenting with signs similar to the signs mentioned in bones, stones, groans, and moans. So make sure that you're really comfortable with that mnemonic. And in terms of treatment for hypercalcemia, so patients are offered saline, and that's really for rehydration. And after rehydrating the patients with saline, we offer bisphosphonates, or we can offer calcitonin. Now, calcitonin works far more quickly than bisphosphonates. So after rehydration with saline, giving the patients bisphosphonates or calcitonin, we can give patients steroids if the hypercalcemia was due to sarcoidosis. Otherwise, we can give patients furosemide, which is a loop diuretic. Now, loop diuretics, such as furosemide, can be given in patients who can't tolerate aggressive fluid rehydration, but use furosemide with caution because it can worsen electrolyte derangement and lead to volume depletion. Okay? So this is the next ECG, so I'll give you 20 seconds for this, or you can pause the screen, it's entirely up to you. Okay, let's find out the answer. Okay, so let's find out the answer of this ECG. So this is an example of hypocalcemia. Now the classic finding of hypocalcemia is a prolonged QT interval. So you count the number of large squares between an RR interval, and the number of large squares at present, you divide that by 2. Now, if your QT interval is more than 50% of the RR interval, then that suggests that you have a prolonged QT interval. Now, if your QT interval is less than 50% of the RR interval, then that suggests that you have a shortened QT interval. Okay? So this is just a summary of hypocalcemia. So hypocalcemia is classically caused by a vitamin D deficiency and by a chronic kidney deficiency. Also, it's found in hypoparathyroidism and parathyroid surgery as well. So ECG features which are suggestive of hypocalcemia involves a prolonged QT interval and also a prolonged ST interval. And from personal experience, I would say that prolonged QT interval tends to classically present in SBAs for medical school finals. Now, in terms of treatment, we offer patients IV calcium gluconate, IV calcium chloride as an alternative, and ECG monitoring is recommended, and ultimately we need to treat the underlying cause. Now, with the treatment for hypocalcemia, IV calcium chloride is more likely to lead to local irritation, so in certain situations IV calcium gluconate might be preferred. Now, another key aspect of hypocalcemia that you need to be aware of are 2 classical signs of hypocalcemia. So these 2 classical signs involve Trousseau sign and Chvostek sign. So we'll firstly discuss Trousseau sign. So Trousseau sign involves the induction of the carpopedal spasm. So when you inflate the blood pressure cuff above the systolic blood pressure for at least 3 minutes, then it will create this carpopedal spasm. So if you have a look on the far right, you can see an example of a blood pressure cuff creating this carpopedal spasm. So this carpopedal spasm is characterized by adduction of the thumb, flexion of the metacarpophalangeal joints, extension of the interphalangeal joints, and flexion of the wrist. Now, another classic sign of hypocalcemia that you need to be familiar with is Chvostek sign. So in Chvostek sign, if you have a look at the picture of the man who's wincing in the bottom left-hand corner, when you press on the patient's facial muscles, so if you tap on their cheeks, it leads to ipsilateral twitching and contraction of the facial nerve anterior to the ear. So essentially it leads to twitching of the lip and the facial muscles after you gently pressed on the cheek. So these are 2 signs which classically come up time and time again in SBA surrounding hypocalcemia, so please keep this in mind during your revision. Okay, so this is the final ECG, and this one should be a little bit easier. This is a spot diagnosis, so I'll give you about 10 seconds for this one, and you can either choose to pause the video or you can wait 10 seconds. The choice is yours. Okay, let's find out the answer. So this is an example of torsade de pointes. So torsade de pointes, when you translate in French, is described as twisting of the points. So if you have a look at leads AVL, V2 and V5, you can see that there's twisting around the axes. So beforehand you had a more positive axis, so that's AVL, that was more positive, and then when we get to V2 it still is a little bit positive, but you can see that the troughs are becoming more deeper, so it's, and then up again in V5. So really you're twisting along that horizontal axis and that's the key classic feature of torsade de pointes, the twisting around the points. And another key feature of torsade de pointes is a prolonged QT syndrome, and I'll discuss that shortly. So the key points that you need to remember for torsade de pointes is that torsade de pointes is caused by lots and lots of different causes. So torsade de pointes is caused by electrolyte abnormalities, and that's why I've included it as part of this video for completion. So torsade de pointes is caused by hypokalemia, hypocalcemia, and also hypomagnesemia. Now, hypomagnesemia isn't particularly high yield, that's why I didn't include it in the video. However, you do need to be aware that patients who suffer from hypomagnesemia, as well as patients with hypokalemia and hypocalcemia, can eventually fall into a scenario where they suffer from torsade de pointes. Other causes of torsade de pointes involves amiodarone, erythromycin, sotalol. Also, tricyclic antidepressants, antipsychotics and chloroquine can also lead to torsade de pointes. So that's why, in terms of monitoring patients who are taking certain medications, an ECG would be really useful in patients who are taking the above medications. So, like I said, torsade de pointes ECG features involves twisting around the axes, and it's associated with a prolonged QT interval. The treatment of torsade de pointes is IV magnesium sulfate. Now, torsade de pointes is important because it's a form of a polymorphic ventricular tachycardia. Like with all ventricular tachycardias, it can deteriorate into ventricular fibrillation, and then unfortunately it can cause patients to suffer from a sudden death. So thank you all for listening today, and I hope you enjoyed the quiz. If you made a few mistakes, then don't worry about it, because the important thing is that you've learned from those mistakes and you'll be able to walk into the exam hopefully with a little bit more confidence than you did prior to watching this video. So if I can please ask you to like this video, subscribe to my YouTube channel and share with your friends, and I'd like to wish you all the best for your final exams, and thank you for watching my video.